Next up is Vivek Reddy, another pioneer in the field of pulse fields. Thank you, Vivek.
Thank you. That was a little while ago. You could tell by my black hair. So I also want to echo Pierre's comments about focusing on VT. Actually, it's not the first company that's focused on VT. The problem is other companies start off focusing on VT and the allure of AFib is just too strong. And I really thank Steve for his almost maniacal focus on VT. My goal here is threefold. I'll try to do this very quickly. First, I want to show you a case that highlights, I think, the technology that Steve has developed. Second, I want to just give you a preview of an abstract that really focuses on the question of full-thickness ablation. And third, I'm just going to pontificate on where I think VT ablation is going. So these are my disclosures. This is an investigational device without regulatory approval. Let me just describe the case and the catheter. So this is a case I did with Peter Newsel recently, a few weeks ago, in the VCAS trial, which is a first-in-human trial looking at this technology in VT patients. The impulse itself is a monopolar pulse, greater than 10 kV. Importantly, the catheter is an 8.5 French catheter. It's irrigated. It has an optical fiber for force sensing. And while it is magnetically enabled, that is not currently being used. The system is not yet integrated with any mapping technology, a critical aspect for the future, I think. The case that I'm going to show you, we used a transeptal approach and a pericardial access. Now, let me just show you the patient. It was an elderly patient. It's actually a patient that that's interesting, that I presented at the PFA live meeting yesterday, but I'm going to go through it very quickly. Elderly patient, reduced ejection fraction. You see the EF of 15% recently before the procedure, who presented for their fourth ablation attempt. And some of the prior cases, both remote navigation had been used as well as the lattice tip catheter. Patient was on amio and a beta blocker, and look here. This is since the last session, about 3 months or so, 2 months. There were 433 events. Lifetime, it's thousands of events. Fortunately, most were PACE terminated, a few required shocks. This patient was having basically daily VT on the few weeks before the procedure. This is our strategy, pericardial access. I'm going to just show this. This is the Pericross system. I'm going to show it because in the US, this just got FDA approved, apparently today. Very simple needle approach where you retract the pericardium and puncture. In any event, we did epicardial mapping at baseline, no ablation. Then we did endocardial mapping, and then, of course, ablation. And then we remapped the epicardium, okay? This is the baseline epicardial map, sort of posterior inferior view. You can see a very large posterior basal inferior scar. And if you look at the image on the right, that's an activation map. And you can see that there's some areas of block. Let's go to so after epicardial mapping, we went endocardial, transeptal. We mapped the endocardium, and here I'm just going to let this play around. On the left is activation, and notice there's some curvature here. And as we turn this around, we're going to show the endocardium in just a second. So that was the epicardium. Now you see the endocardium, and you see again this overlying area. There's all those little dots because that's the area endocardially where we saw a lot of fractionation, late potentials. Also some on the epicardium. At that location, you can see if we do S3 mapping, for example, you can barely see it, but there's actually a very, very late potential. There clearly is some functional delay here. Okay, we didn't want to induce VT in this patient. The patient had a really reduced ejection fraction. We didn't want to put in a support device. So we mapped in sinus rhythm. You already saw the late potentials, et cetera. Then we delivered our lesions. And I'm not going to show you all of that in the interest of time, but these are the actual locations for the lesions. Each lesion, by the way, is 5 impulses, each taking about 200 milliseconds or so. So it's boom, boom, well, 5 times. Anyway, you get it. So these are the endocardial lesions that we delivered. And this is the mapping post-ablation. And I'm not going to show you all the details, and red is just a color. The reality is all of those potentials on the epicardial surface were eliminated by endocardial ablation. So large inferior wall with septal lateral extension, 20 endocardial-only lesions result in epicardial elimination, 24 minutes of transpired ablation time. There were no complications. Actually, we're going to show the VCAS trial as a late breaking later this meeting. But there's something else I can show you. This is a abstract that we have a poster that's going to be, I think, shown tomorrow. And so I just want to take you through some of this, because showing one case where you have epicardial elimination, I mean, that's very interesting, but I don't think that convinces any of you. But here's a few cases. So this is, again, the same study, of course, endocardial mapping, then, epicardial mapping, then endocardial mapping and ablation, and then epicardial remapping. Again, 5 applications at each location. So this is a population of patients with reduced ejection fraction. The time from most recent MI was 8 years. And if you see prior ventricular ablation in 3 of the patients, 2 had VT storm. And here's what you see: pre-ablation on the right, post-ablation on the left. So these are epicardial maps you're looking at: pre-endo ablation on the left, post-endo ablation on the right. So these are transmural lesions. Okay. Now, you could argue, and this would be an appropriate point, this is acute remapping. What happens 3 months later? I don't know. So there were a total of 8 patients that we mapped. If you look at the number of lesions, 19. The transport ablation time was 29 minutes, which I think is quite good given the fact that we didn't have integration with mapping. We're like going back and forth between the ablation catheter and the mapping system. We did do pre-post induction in 5 of the patients. All were inducible pre-ablation, none were inducible post-ablation, to the extent that that matters. And there was epicardial voltage abatement and actually elimination of all fragmented late potentials in all of these 8 cases. So what we concluded were 2 things. One, at least with this number of patients, we could reproducibly create what appears to be transmural ventricular lesions. I think this is an important point. You know, when you look at preclinical data, I mean, we should be getting transmurality with almost every single ablation technology. I mean, we should have been getting transmurality with RF ablation, if you look at the actual preclinical data. But the translation from preclinical to clinical is always different, and I don't fully understand why. But so, for me, this is a very important point. I also think, by the way, this idea of epicardial remapping could be an important endpoint for future substrate modification studies. So, I'm near the end here. I just want to talk about VT ablation. I mean, when we would actually employ this. I'm now thinking about ventricular ablation as either VT ablation in patients who have multiple VT episodes who are coming in because of this issue, or I'm thinking about it from the perspective substrate modification as a strategy to quickly, safely, efficiently modify the substrate to render the ICD as a real backup. Right now, most of the patients are being treated at the far right. They're getting ICD therapy. But remember, there are now studies, I should say, such as Partita, which in the patients who had their first event, there was a significant difference in outcomes. Now you could say there was an unusual study, fine. Survive VT, this is a multi-center study, again showing improvements in outcome of a composite of mortality, shocks, heart failure hospitalization, and complications. 50% reduction in events. Okay, 7-8 centers, only 150 patients, fine. Now we have Vanish 2. This is 400 patients. This is not a small study. And a composite endpoint, again, of hard endpoints of death, appropriate shock, VT storm, sustained VT. And you see a 25% reduction in events. So I do think, and I echo what Pierre said, I think that with good tools, we'll get effective scar VT ablation. And as you saw, I believe that we're getting transmural lesions. I think VT ablation is going to be very efficient. You can imagine integrating this with imaging, for example, and doing this procedure very efficiently. For the non-VT storm patient, where you're doing substrate modification, I will be surprised if we're not doing same-day discharge within 2 years. Finally, I do think that looking at high-risk patients, we'll be doing VT ablation to really render the ICD as a backup. Thank you. Oh, I couldn't forget my advertisement. VT Symposium in Philly this year. Thanks.
Thank you, Vivek. Thank you, Vivek.